So at this year's EHA meeting, we're presenting data of a large real-world cohort of lymphoma patients treated with CD19 CAR T in the licensed indication in the UK. Data on 12 months of the national program. It's nearly 2 years ago since 2 CD19 CAR T products were licensed for high-grade lymphoma patients who failed 2 or more lines of treatment. And we know that treatment options are very limited for this patient population. So essentially palliative. So that's why everybody was very excited when the pivotal trials, Zuma-1 and Juliet, reported a few years ago their outcomes suggesting that up to 35 to 40% of patients in this refractory relapse group might have long-term benefit from CAR T. But of course, these trial data have to be confirmed in the real-world setting. And it's also important to gather real-world data across different countries and healthcare systems to adequately assess the true clinical benefit and health economic implications. So I think the unique feature of our data set is that it's a prospective entire national cohort, so the so-called intention to treat population, reflecting the outcome of lymphoma patients at the time they are considered for CAR T. So at the time when a patient has to decide whether to embark on the CAR T pathway or choose alternative treatments. We've altogether included around 250 patients who were approved and deemed eligible. Of those, only 183 patients were actually infused. So we're still seeing a quite significant dropout of patients during this relatively long manufacturing process and in the time lined up for CAR T. Of the patients who were infused with CAR T, around 40% of patients are alive and without progression at 6 months. And toxicities we've seen were quite favorable compared to other data sets. So a relatively low proportion of patients who had severe CAR T-related toxicities, such as cytokine release syndrome or neurotoxicity. So in the end, I think what these data set demonstrates is that firstly, that NHS England has successfully implemented a broad national structure for delivery of this fairly complex treatment, providing transparent, effective and equal access for all patients across the country. Our outcomes are quite in line with what French real-world data set have published, and fairly in line with the 2 pivotal studies, although there could be a slightly inferior efficacy in our data or in the European data set, but I think it's overall too early to say. If there was a true difference in efficacy, this might be due to differences in patient selection and also quite different and longer turnaround time in European centers compared to the States. But overall we need to wait longer follow-up data to know if there is a true difference. Toxicity outcome in our cohort is very promising, so a favorable toxicity profile, so it's clearly safe to deliver CAR T within the NHS. Apart from the longer turnaround time that really has to be tackled by the manufacturers, I think for the future the most important issue will be to identify patients who clearly do not benefit from treatment, to better to improve patient selection, and there are certain factors like elevated LDH, etc., that has been shown to be a negative prognostic factor in different data sets. So this should guide our selection in the future. Our median time was from apheresis to infusion 42 days. And it's around 20 days in the States. And overall, from approval to infusion, it was 56 days in the median. So it significantly came down in the second 6 months of the program, but it's still, there are certain delays really determined by the manufacturers, and they are about to build up capacity in Europe, and that will change the whole setting. But at the moment, we don't have the setup as in the States, and that might indeed have impacted on outcome.